Good afternoon, ladies and gentlemen, friends and colleagues. It's an honor to speak to you today at the 61st session of the UN Commission on Narcotic Drugs on a topic of the highest public health importance: the impact of drug policies on the HIV epidemic, particularly among people who inject drugs, PWID, their families, and broader communities. As the world has embraced the Sustainable Development Goal target of ending AIDS as a public health threat by 2030, the current data suggest that this target will not be achieved unless we can do better in delivering essential and life-saving services for people who use drugs. UNODC, WHO, UNAIDS, and the World Bank estimate that globally 11.8 million people, with a range of 8.6 to 17.4 million people, inject drugs, of whom roughly 1 in 8, or 1.55 million, about 13%, are living with HIV infection. Among the many groups affected by HIV/AIDS, people who inject drugs suffer the greatest burden of untreated HIV disease, and those at risk for infection have the lowest access to HIV prevention services. This must change. In 2016, in an effort to inform the 2016 UNGAS on drugs, we reviewed the scientific and public health literature to assess the impacts of drug policies and practices on human health. These findings were reported in The Lancet in March of 2016. What we found was that drug policies, if not based on evidence and human rights, can contribute to worsened discrimination, undermine people's right to health, and that they have increased HIV, hepatitis C, and tuberculosis transmission by limiting access to HIV harm reduction services and through the multiple effects of mass incarceration on people who use drugs. When gains in reduction in sexual transmission of HIV are being seen worldwide, HIV transmission linked to unsafe injection of drugs, both opiates like heroin and increasingly with stimulants in some settings, continues to drive HIV incidence in many regions, including Eastern Europe and Central Asia, and in South, Southeast, and East Asia. The prevalence of HIV infection among people who inject drugs is many times higher than that in the general population in nearly all countries studied. The latest UNAIDS analyses on new HIV infections suggest that globally, people who inject drugs accounted for about 8% of all new infections and for 20% of new infections outside sub-Saharan Africa in 2015. Although the incidence of HIV declined by 35% globally from 2000 to 2014, new infections increased by 30% during that same period in Eastern Europe and Central Asia, where unsafe drug injection accounts for about 65% of cumulative cases. Despite the fact that HIV among people who use drugs is actually among the simpler modes of HIV spread to control, why are we seeing ongoing and rising transmission among PWID in the fourth decade of the HIV pandemic? Where people who use drugs have good access to the WHO, UNODC, UNAIDS comprehensive package of services, also known as harm reduction, the rates of new HIV infection have been consistently reduced. No form of treatment of any drug dependence has as vast a scientific evidence base as does opioid substitution therapy with the opiate agonists methadone and buprenorphine. A 2012 meta-analysis of studies from Europe, North America, and Asia concluded that oral OST reduces the risk of HIV transmission among people who inject opioids by 54%. Yet globally, only about 16% of people who inject drugs receive OST, and only about 33 needles and syringes are distributed per person who injects drugs annually. Both are well below the required high coverage targets for achieving impact for preventing HIV and hepatitis C. Worryingly, less than 1% of people who inject drugs live in countries with high coverage of needle and syringe exchange and OST. HIV treatment access for people who use drugs and who are living with HIV also plays essential roles in saving lives and in epidemic control. Denying treatment to HIV-positive people who use drugs ensures that they and their injection and sex partners will be at risk for HIV and violates the rights of all concerned. Nonetheless, people who use drugs are commonly and sometimes systematically excluded from antiviral treatment for HIV disease. A 2014 review of HIV services in 5 countries with the largest number of people who inject drugs estimated that less than 5% of these people living with HIV had access to treatment. Access to services is poor in too many countries, largely due to fear of arrest. UNAIDS' 2014 report on gaps in the global HIV response summarized the crisis of inaccessibility of ART for people who inject drugs and highlighted that in sub-Saharan Africa, where drug use is rapidly expanding in several countries, less than 1% of people living with HIV who inject drugs were receiving antiviral treatment. The lack of predictable and sustainable funding for comprehensive services for people who inject drugs is a major challenge in 2018. The Global Fund's investments from 2002 to 2014 were transformative, investing some $620 million in harm reduction services in 58 affected countries. The Global Fund's change in the funding model in 2011, which ended support for many high and upper middle income countries, proved challenging for many countries with large drug-injecting populations. With the decline in Global Fund funding, many countries did not replace donor funds with national resources, leading to major funding gaps and program losses. The estimated global shortfall for comprehensive HIV services for people who inject drugs was $2.3 billion in 2015. What are better ways forward in the SDG era? First, incarceration is expensive and has failed as drug dependence treatment. The use of various alternatives to incarceration for minor drug-related offenses has reached more people with social services, allowing law enforcement agencies to focus on high-level trafficking offenses and not on increased substance use, and have not increased substance use. Comprehensive HIV services, which are based on evidence, human rights, and are gender responsive for people who use drugs, save lives, reduce disease transmission, and can serve as an entry point for treatment for those who want it. Overdose deaths can be reduced by ensuring that opioid users have access to OST and that people who use or who may witness overdose have access and are trained to deliver naloxone. And finally, it is clear that people who use drugs have been shown to be highly interested in utilizing HIV and viral hepatitis services and treatment when those services are offered in safety and in dignity. We can and must do better. Thank you for your attention. Thank you for your efforts to improve the health and well-being of these vulnerable individuals and communities.